Hello everyone, today we are going to study orthopedic disorders of the shoulder and elbow. First of all, let's learn the anatomy of shoulder and elbow. In the shoulder and elbow, we first look at the anatomy of the shoulder. The shoulder joint is the connection between the upper limb and the trunk, and is the basis of upper limb functional activities. It mainly includes four parts: the glenohumeral joint, sternoclavicular joint, acromioclavicular joint, and the scapulothoracic structure. Among them, the glenohumeral joint is a ball and socket joint composed of humeral head and scapular glenoid. The articular surface of the humeral head is about 3 times larger than the glenoid, and the anterior substructure of the articular capsule is loose and weak, which forms the flexibility of shoulder joint movement and the characteristics of AZ dislocation. The anterior, posterior, and upper parts of the shoulder joint are reinforced with ligaments and muscles. The anterior part mainly includes superior and middle glenohumeral ligaments, subclavicular muscle, pectoralis major, and anterior part of deltoid. The posterior part mainly includes infraspinatus, teres mirror, and the posterior part of deltoid. The upper part mainly includes supraspinatus, conchohumeral ligament, long tendon of bicep brachii, and the upper part of deltoid. The lower part is the glenohumeral ligament complex, and the articular capsule is loose without muscle protection and relatively weak. There are 3 groups of ligaments in glenohumeral joint, among which glenohumeral ligament can strengthen the anterior wall of articular capsule. The coracohumeral ligament is the suspension structure of glenohumeral joint, and the coracoacromial ligament can prevent excessive upward movement of the humeral head. The stability of the shoulder joint mainly depends on the coordination and balance of the muscles. The main surrounding muscles include deltoid, latissimus dorsi, teres major, pectoralis major, and rotator cuff, among which the rotator cuff consists of supraspinatus, infraspinatus, teres mirror, and subscapularis. Next, let's look at the clavicle. The forelength of clavicle is subcutaneous. The medial half is lordotic and the lateral half is kyphotic. The appearance is inverted S shape. The inner 2/3 of the clavicle is triangular in cross section. The outer 1/3 is flat, and the middle 1/3 is a predilection site for fractures. If the fracture of clavicle is severe, it can damage the above important structures. The subclavian arteries, veins, and brachial plexus nerve pass through the back of the midclavian segment, and below it is the capsular peroneum. The proximal humerus can be divided into 4 parts: head, neck, and greater and lesser tuberosities. The humeral head is semicircular, inclines backward, upward, and inward, and forms the glenohumeral joint with glenoid with scapula. The joint between humeral shaft and humeral head is the anatomical neck, while the surgical neck is located 2 or 3 centimeters below the anatomical neck. It is the junction between the dense bone and the cancellous bone, and is also a predilection site for fractures. Next, let's take a look at the anatomy of the elbow. The elbow joint consists of branching ulnar joint, the humeral radial joint, and the proximal radial ulnar joint, which are wrapped in the same articular capsule. The articular capsule of the elbow joint is strengthened by bilateral collateral ligaments, and the anterior and posterior are relatively loose and weak, but the anterior is strengthened by muscles and tendons. Besides, due to the function of the olecranon and the triceps brachii ligament, no matter the elbow joint is extended or flexed, the elbow joint can be protected. Compared with the posterior of the elbow, the ulnar coronoid process and olecranon are smaller, and the ability to resist the backward displacement of the ulnar is poor, so the elbow joint is prone to posterior dislocation. Let's look at the characteristics of these three joints in detail. First, the brachial ulnar joint is mainly composed of humeral trochlea and the olecranon notch of ulnar. It is a trochlear joint and can perform flexation and extension exercise on the coronal axis. However, the inner side of the inner and outer limbs of the humeral trochlea protrudes from the outer side, especially when the humeral trochlea is fully extended and externally rotated. The ulnar is on the outside of the axis of the humerus, forming an angle of 5 degrees to 20 degrees, which is the carrying angle. Secondly, the humeral radial joint, which is composed of head-shaped humerus and capitulum radial fossa, is a head fossa joint. The capitulum and trochlea are located in front of the axis of humeral shaft, forming an average of 45 degrees. Third, the proximal radial ulnar joint is composed of annular articular surface on the upper end of the radius and the radius notch on the upper end of the ulnar. It completes the rotation of the forearm together with the distal lower ulnar flexible joint. The annular ligament wraps around 4/5 of the proximal radial ulnar joint and forms a cup shape with the ulnar notch, which is wide at the top and narrow at the bottom to prevent the radius from shifting to the distal end. Next, let's take a look at the physiology characteristics of elbow joint. First, it is a soft tissue around the joints. The articular capsule of elbow joint is relatively loose, and its upper part is attached to the radial fossa, coracoid fossa, and olecranon fossa of humerus. The adhesion on both sides is lower, generally on the medial and lateral epicondyle and trochlea, and on the bone surface of upper edge of the head-shaped articular surface. The lower part is attached to the annular ligament of radius and the bone surface of the inner edge of the semilunar notch of the ulnar. The collateral ligaments on the ulnar and radial sides strengthen the stability of the elbow joint. Secondly, nerves and blood vessels. There are several important nerves and blood vessels in the elbow. Among with the medial nerve, brachial artery descends to the front of cubital fossa among the medial bicipital sulcus in the upper arm, and enters the forearm under the aponeurosis of bicep braching. The radial nerve is divided into superficial and deep branches in front of the lateral epicondyle of humerus, and the deep branching is closer to the lateral condyle of the humerus. In the extension type supracondylar fracture of humerus, several violence tend to cause injuries of brachial artery, medial nerve, and radial nerve. Thirdly, the elbow muscle and joint movement. The main function of the elbow joint is flexation, extension, and rotation. Its range of motion 135 degrees to 114 degrees of flexation, and 0 degrees to 15 degrees of extension. Brachial muscles and biceps braching are the main muscles for elbow flexation, and biceps braching still has powerful supination. Brachial radialis, pronator teres, and extensor carpi radialis longus and brevis can assist elbow flexor and forearm pronation. The triceps branching and posterior elbow muscles are the main muscles for elbow extension. The rotation of elbow joint is mainly accomplished by humeral radial joint. The humeral radial joint has two motion axes. The horizontal axis of flexation and extension is consistent with the motion axis of brachial ulnar joint, which pass through the capitulum radial and the capitulum ulnar respectively. Elbow flexation and extension moments and forearm rotation moments are often combined. You should have known something about the anatomy of the shoulder and elbow. So what method should be used to check if shoulder and elbow are damaged? Next, let's learn the special examination of the shoulder joint. First, the Dugas sign, also known as the Dugas test. The injured limb is flexed at the elbow, while the hand rests on the opposite shoulder. If the elbow cannot be made to touch the chest wall, it is positive, indicating the shoulder dislocation. Secondly, long head tension test or bicep breaching. The patient bends the elbow, the forearm is supinated, and the examiner gives resistance. If there is pain in the internodal sulcus, it is positive, indicating biceps brachial long head tendinitis. Thirdly, shoulder joint abduction and right test, also known as pain arc test. If the patient's upper extremity abduction of 0 degree to 16 degree without pain, 16 degree to 120 degree with pain, and then rise 120 to 118 degree without pain, it is positive, suggesting a chromium impingement syndrome. Finally, let's look at the special examination of elbow joint. First, wrist extensor tension test. The patient strengthens the affected elbow joint and the forearm is pronated. The examiner flexes the affected wrist joint. If there is pain at the lateral epicondyle of humerus, it is positive, indicating lateral epicondylitis. Secondly, cubital triangle. Under normal circumstances, when the elbow joint is strengthened, the lateral epicondyle of humerus, the medial epicondyle, and the ulnar or lateral are in a straight line. And when the elbow joint is flexed, the three form an isosceles triangle. When supracondylar fracture of humerus occurs, the relationship among the three remains unchanged. When the elbow joint suffers posterior dislocation, the relationship among them changes. Thirdly, elbow joint abduction and adduction test. The patient's elbow joint is in an extended position. The examiner holds the upper part of the elbow joint with one hand, and the other hand holds the forearm to abduct or adduct it. If the elbow joint is passively abducted and adducted, abnormal lateral movement occurs, suggesting collateral ligament rupture, lateral condyle fracture, medial epicondyle fracture, or caputatum radial fracture. Well, that's all for this lesson. I hope you can actively review it after class. Thank you.